Welcome to today's session on systemic lupus erythematous, SLE for short. So first thing is, what do the three images have in common? On the left-hand side, we've got Seal, a very famous musician. In the middle, we have Remus Lupin, a Harry Potter character. And on the right-hand side, we've got a wolf. Well, so in the right-hand side, left-hand side, Seal suffers from a condition called discoid lupus, and it's known for its characteristic lesions on the skin, or the scarring on his skin. In the middle, Lupin, who's a character who transforms into a werewolf, so Lupus and Lupin. And the third thing is Lupin in Latin is wolf. So this is they give it the lupus name derives from the characteristic facial rash because of the wolf's bites that kind of resemble the erosive lesions that discoid lupus gets. So let's get on with the next of the how lupus kind of starts off. So what is lupus? It's a multi-system autoimmune disease. So it produces antibodies, autoantibodies against ourselves. Lupus has a pattern where there's lots of flares and remission throughout the years. And in terms of risk factors, there is a number that we can look at. So very common with a lot of autoimmune, environmental. So we can look at smoking, silica exposure. It seems to be correlated with hormonal exposure. So especially in pregnancy, SLE tends to flare up. There is also genetic predisposition as well, so with certain genes, and there is a genetic deficiency of the classical pathway of the complement protein. So what is a complement protein? Complement proteins are important proteins that are very important in our immune system. What they do is they coat things that need to be deleted or getting rid of in our body. So what it does, it attracts white blood cells to come and get rid of items in our body. So in our body, cells are dying every day, inducing into apoptosis, so cell death. And this needs to be cleared away. And complement protein is a very important protein that can alert the white blood cells to come clear it away. And abnormality in this process actually leads to lupus, and we're going to talk a bit about that soon. There is also something called drug-induced lupus. So it's not SLE, it's a different sort of category, but it has lupus-like symptoms. And there are certain drugs like proclenamide and hydralazine that are associated with this. Classic symptoms, there is a fever, arthralgia, and rash. So they talk about the mallow rash, the discoid rash, and the photosensitive rash. And we'll talk more about that soon as well. So as we talked about, females tend to be more able to get associated with getting SLE than males, and it's more common in our younger ages. And this might be explained due to our estrogen exposure as well. So here we've got a diagram of a general idea of how S cells induces apoptosis or cell death, and complement protein usually clear that away. So here, while the cell is dying, there is a release of all those internal structures of the cell. This includes nuclear antigen. If it's not cleared away appropriately, then B and T cells then can interact with this and formation of, we've got our antibodies against ourselves. So, like we said, it's a deficiency of the complement protein. So because we're not clearing away what needs to be cleared, it leads to more likelihood of that apoptotic cell, so our own cell products being recognized by our immune system, and then it induces an attack on ourselves. So because it's not cleared away, our macrophages don't clear it away appropriately, so it gets picked up by our T cell and it activates B cells, which then say that they recognize this as a foreign object or foreign body, and then they induce antibodies to get rid of this. The problem is when it starts attacking our own body, it can lead to different sorts of symptoms. So as you can see, once it binds to little products, there is one way that it can induce damage. One way is it binds to these products, forming immune complexes. And this can go and deposit in various parts of our body. So it can deposit in our glomerulus, so our functional units of the kidney. So here it deposits in our kidney. Then our complement system activates, so C3 turns into C3A, C4 also gets used up, and then this attracts immune cells to come and destroy whatever organ it's just been deposited in. So this is our type 3 sensitivity reaction. The immune complexes deposition leads to complement activation and inflammation. These antibodies itself can go and attack antigens on our cells, such as blood cells and platelets as well. So that's another important type 2 sensitivity reaction that we've got to think about. So the most common autoantibodies is anti-nuclear antibodies. And unfortunately, it's positive in a lot of connective tissue disorders and autoimmune conditions. So there are specific types of anti-nuclear antibodies that are associated just with SLE. So anti-double-stranded DNA, present in about 70% of SLE, but without SLE, there's also 0.5% of patients that do also turn out to be positive. Antihistone, anti-Smith. So as you can see, all these antibodies are against parts of our cells. So anti-double-stranded DNA, antihistone, so we've got our histones, and anti-Smith is our ribonucleoproteins that are also present in our cell nucleus. So what sort of symptoms do we see? Well, one of the symptoms is you can have cutaneous and mucosal complications. So you can also have mucosal ulcers. They can also have skin rashes, which we'll talk about, and even alopecia as well. We can also have neurological complications and constitutional symptoms and fever. In terms of the lungs, pleural effusion, pleuritis, and inflammation of the heart, so pericarditis and effusions. We can also think about renal complications, a very common example we talked about previously. Immune deposition in the kidneys can lead to lupus nephritis, so inflammation of the kidneys. We can have gastrointestinal complications. It can affect our hematological, so we can have anemia, thrombocytopenia, because of our antibodies interacting with these cells. There is also Raynaud's phenomenon, which is, we talked about in a previous session, where vasoconstriction of our peripheries of our hands, usually due to stress or cold stimulus, can actually cut off circulation temporarily to our hands. And you can also have arthritis, arthralgia, so inflammation of the joints. This is all due to complications due to the immune deposition in various parts of our body. So it's a multi-system disease. So cutaneous lupus erythematous. So we'll talk about our skin issues. So we've got acute cutaneous lupus erythematous. This is associated with active lupus. And when you're having these flares of lupus, we're going to be seeing these sorts of rashes. We're going to have discoid lupus erythematous. So these are scaly plaques that lead to the scarring. And this is the one that we've seen in our famous musician seal. Subacute cutaneous lupus erythematous. So this is also associated with photosensitivity. It can also have papular eruptions and scaly plaques, which transform into annular psoriasiform lesions. But these usually resolve without scarring. It's very important to note that these two, so the discoid and the subacute, are separate entities to SLE itself. They have similar sorts of treatments, but they're not SLE, and they lack the systemic inflammation and the multi-system disease that lupus has. So they're just affecting the skin itself. So this is our first one. So this is our acute cutaneous lupus erythematous. So this presents with our classic malar rash. So appears in the skin, and you can see a characteristic nasolabial fold sparing. So it doesn't affect these regions. So it's called a butterfly rash as well due to its shape. You can also have a photosensitivity, so maculopapular rash, very similar to a sunburn kind of picture. So discoid rash. So these are more scaly plaques, and this can lead to, you can see there's peripheral hyperpigmentation and central hypopigmentation, and this can lead to scarring. So while it has similar approaches in management in terms of lupus, it lacks a systemic symptoms, and there is around less than a 10% conversion of these patients to lupus later on. So some of them do turn out to develop lupus. The last one is subacute cutaneous lupus erythematous. So this sort of very photosensitive skin starts off with, we said previously, our papular eruptions, which can then later turn into a psoriasiform and annular lesions as well. All right, so there are different variants. There's drug-induced as well. So this is also a separate entity. It has lupus-like symptoms. Again, lacks the skin and renal manifestations usually. It has genetic susceptibility. So it's associated with something called decreased acetyltransferase activity. So this enzyme is very important for metabolizing a lot of our medications. And due to decreased of this level of this enzyme, it results in more interaction with our medication, with immune cells, and then development of antibodies. So common triggers sulfur drugs. Non-sulfur drugs are procainamide and hydralazine are two major ones. In terms of our blood test, it's associated with antihistone antibody elevation, but anti-DSNA, very common with SLE, is not usually elevated. So treating is usually ceasing the drug, and it usually self-resolves within weeks. How do we diagnose SLE? So usually we have a EULA ACR 2019 criteria, which is the most recent as of today's date. And you based on ANA positivity and at least one clinical criteria, and then it has to have an additional criteria that add up to about 10 points. So it's clinical and immunological. So here we can have, you need a positive ANA titer, and then you can apply the additional criteria. So make sure that if there is a more likely explanation for this fever, it doesn't count as SLE. And it has to add up to 10 points. They have different weightings. So you can have clinical, you can have constitutional, hematological, neuro, psychiatric, full systems as we talked about previously. And also you've got immunological. So this is our autoantibodies that's associated with it. So as you can see, some of these are called antiphospholipid antibodies. We're going to talk about that a little bit later. Complement proteins. So remember when our immune complex is deposited in the kidneys, it started using up a lot of our complement proteins to induce inflammation. So when we have low C3 and low C4, it indicates that there is probably an SLE occurring. And also we talked about our characteristic DSNA and anti-Smith antibodies as well. This is a previous criteria. This keeps coming up a lot because the other one was a bit more recent. It's important to be aware of this one as well. So this one's at least 4 out of the 17 criteria. You need at least 1 clinical and 1 immunological. But if you have biopsy-proven nephritis in the presence of ANA or anti-DSNA, it's already enough on its own to meet the criteria. So other relevant investigations. So we've got full blood count, UEC, LFT. We talked about why we order our complement proteins, coagulations, because these can also be disturbed. We talked about our different sorts of antibodies. So antiphospholipid syndrome is an associated syndrome that occurs in lupus. What is characteristic is that this leads to a more thrombogenic state. So it allows patients to get more clots more easily. We'll talk more about that in the next slides. Urinalysis, urine protein, creatinine ratio, very important to monitor our kidney functions because our kidneys can be affected in lupus. And ECG can be appropriate as well. It can detect any cardiac manifestations such as inflammation. So we can also do a histopathology, so a lupus band test and a kidney biopsy. So lupus band test is usually a biopsy of the skin, and it can use staining to detect antibodies in terms of the skin. We can actually compare it in terms of things like discoid lupus, which occurs without the systemic involvement. If we take a biopsy of normal skin and the rash involved, discoid lupus would only have positive in that rash itself, while SLE, systemic lupus erythematous, will have positive even in normal skin. So it's a systemic involvement. And any relevant imaging, so chest, joint x-rays, chest x-rays, depending on the organ involved. How do we manage SLE? So general management, we want to avoid things that can trigger it. We want to avoid cell damage that can allow interactions with our antibodies and our cells. So we want to avoid smoking. We want to avoid UV light exposure with sunscreen. Lifestyle factors is very important to managing our health. Immunization before starting on a lot of our immunosuppressants, which they may be on. If it's just cutaneous manifestation like skin, we can consider topical steroids and topical calcineurin inhibitors, which are immunomodulators. We can also think about symptom relief, so simple analgesia, so non-steroidal anti-inflammatories, so NSAIDs would be most appropriate too. Very important to advise them on planning their pregnancy. So in terms of pregnancy, it can actually lead to an exacerbation of symptoms. Also, the medications that they're usually on may interact and may be teratogenic. So it can induce malformations or abnormalities in the fetal growth of the baby. So it's important to plan that as well. And it's also, in terms of pregnancy, spontaneous abortion, if they have antiphospholipid syndrome, where they're more likely to get clots, should be also considered as well. So systemic therapy, the basic therapy is hydroxychloroquine. So we can also add methotrexate or azithromycin, which are immune depressants if there is no response. So this is usually what they're usually on, and it's shown to also decrease the number of flares during the disease progression. Induction agent will depend on the presentation. So if they have a flare, if they're very mild symptoms, oral glucocorticoids. If they have more severe symptoms, so mild symptoms would be more arthralgia, the mallow rash. If they have more severe symptoms, so if they're having lupus nephritis or any sort of severe inflammation, we can consider doing oral glucocorticoids and immunosuppressive agents, so mycophenolate, cyclophosphamide, or even biological agents. So these are our monoclonal antibodies that we can also use. Organ damage, so once it starts affecting organs and critical organs, we need to start thinking about IV glucocorticoids and IV immunosuppressive therapy. Similar sort of thing, but more IV route. So where does these medications act? So glucocorticoids can influence a lot of our immunoregulators and depress our immune system, allowing a more calming effect on the body. Immunosuppressive agents can influence T cells and B cells, so decrease the activity of those. And monoclonal antibodies, such as biological agent over here, these can go against B cells and actually inhibit their functions. So prognosis is usually quite good in terms of if it's managed well. There's about a 10-year survival rate. It's about 90%. In terms of what causes mortality in these patients, initially it's due to either active disease from their neurological involvement, so central nervous system involvement, or renal disease, or infections that they may occur when they are immunosuppressed due to the medications that they're on. Later down the track, it could be complications of the SLE. So if it affects their kidneys until they get end-stage renal disease, or even cardiovascular disease. So we know that due to the inflammation, they are at an accelerated risk of having atherosclerosis that occurs at a much faster rate as well. And this seems to be the biggest cause of death in these patients. So antiphospholipid syndrome. So what are these? So you know how in lupus it is antibodies against a lot of our antigens in our body because it's not cleared away appropriately. So these while these antibodies are usually anti-nuclear, as we talked about previously, it can also occur against the phospholipids in our cell membranes. What's the problem with this? Well, it can deactivate a lot of our anticoagulating proteins. So there are proteins in our body that make our blood more thin in a way, so it will make it less likely to clot. And it can deactivate a lot of those factors. It can also activate platelets and result in more clotting in a more thrombogenic state. So in terms of diagnosing, if there is evidence of venous or arterial thrombosis, and or if it has adverse pregnancy outcomes, so because of this thrombogenic state, it can affect a lot of our risk of having a pregnancy. So miscarriages may be more common, or even during pregnancy, a spontaneous abortion may be more common. So there's a wide range of adverse pregnancy outcomes. So, and you need the evidence of antiphospholipid antibodies as well. It can be primary or it can be secondary. So this can happen all on its own, or it can happen secondary, like in lupus. And it can also happen with other autoimmune disorders as well. So here we can see the antiphospholipids can activate endothelial cells on monocytes, and they can increase our tissue factors. So this can encourage more clotting. Tissue factors is can definitely encourage the coagulation cascade and encourage the clots to occur in our body. It can also activate platelets directly to induce thrombogenic state. As we talked about previously, it can deactivate protein C. So this is a very important anticoagulating protein. It can activate prothrombin. So this one, it can activate it and turn it into thrombin. And thrombin encourages clots to form as well. And it can also activate our complement system. And together with other sorts of issues in our body, such as inflammation or estrogen exposure, it can all encourage the formation of venous arterial clots. So how does it present? Coagulation defects. So we can remember it through clots, C-L-O-T. Coagulation defects, livedo reticularis, which is a characteristic skin condition that occurs that you can classically see in the legs due to formation of clots during our small arterioles in our legs. Obstetric complications, as we talked about previously, any thrombocytopenia and thrombotic tendencies that can affect other vessels in our body. So a nice way to remember it as well. And we talked about what the importance of having a history of miscarriages and thrombosis. Our antibodies we look for is lupus anticoagulant, anti-cardiolipin antibodies, and anti-beta glycoprotein antibodies. So these are the three main ones that we look at. So why is it called lupus anticoagulant? Is it meant to be more coagulant rather than anticoagulant? Well, it's a misnomer in a way, because lupus anticoagulant, the presence of this can actually increase our APPT time. So APPT is a way we can measure our coagulation, so how well our blood clots. And it can actually increase this time. So it makes it appear that our blood is less likely to clot, when in reality it's not. So why does it do that? It's because when we send off our blood sample to observe for our APPT time, our lupus anticoagulants, these antibodies, interact with a lot of our prostaglandins that are so not prostaglandins, sorry, phospholipids that are present in that test tube that induces clotting. So it interacts with them and it makes it less likely to clot. And that's why it increases the time. And that's why it's called anticoagulant. So it looks like it appears to have less likely to clot, but in reality, it's not. So anti-cardiolipin and anti-beta-2 glycoprotein. So this is associated with thrombocytopenia, hemolysis, and leukocytopenia. So why is it associated with thrombocytopenia? Well, it induces clots, so it gets used up in our body, right? So that's why you get thrombocytopenia. Also, these antibodies can cross-react with our blood cells, red blood cells, and white blood cells, and it can also lead to hemolysis, so breaking of our red blood cells, and reduced white blood cells. So we can have a lot of manifestations in our body. So you can have migraines, you can have strokes and TIAs due to the clots. It can form in our lungs. It can form in our heart, so coronary artery disease. It can form in our kidneys. It can lead to miscarriages, intrauterine fetal death, and associated with obstetric complications, so intrauterine growth restriction and preeclampsia. So here's a characteristic rash that we talked about, livedo reticularis, and it can also lead to clots in our deep veins. How do we manage it? Usually through heparin. So low molecular weight heparin is usually the way to go. If severe, we can think about the addition of glucocorticoids and even plasmapheresis and immunoglobulins to get rid of these antibodies. Secondary management. So how do we prevent them? So once we treat the clot in their leg, how do we prevent them from having it? Usually through warfarin. So I know when we have a clot in our leg, like a DVT, there is a lot of new medications that are out there, but the evidence is not there yet for antiphospholipid syndrome. So the evidence is usually to start them on warfarin. And we can also consider the addition of aspirin, depending if they have other risk factors for maybe cardiovascular risk factors. We can think about the addition of aspirin as well. So that concludes it for the session on SLE. Thank you so much for watching. And if you have any questions or queries, put them down in the comments below. Also, let me know what you want to see next. And don't forget to subscribe, and I'll see you guys next time. All right, take care. Bye.